In my practice, I often see people that develop pain in the forefoot region. While this can be a neuroma, and it can also be arthritis, most often it's what I call a crossover second toe. And this deformity is named that because the second toe is the most commonly involved, and it usually crosses up and over the big toe. When it really starts, it may be without any deformity and just some vague pain in the forefoot that's very hard for a patient to isolate, and it may take time, both your time and my time, and it may take several examinations in order to really pinpoint where the pain is coming from. In time, a severe hammer toe deformity may occur, as we see in this photo, and here you see that where the toe, it really cocks up and deforms. And now in this x-ray, we also see a dislocated second toe that's associated with a crossover second toe. But that's not always the way it takes place. Often, when a patient first comes in to see us, they talk about a vague pain in the forefoot, and they really have very little, if any, deformity. It's only as time passes and these deformities start to occur that we get a clue. Now, as we see these photographs with a very mild deformity, and then in this next photo we see a more severe deformity, and then in this last photograph we see a more severe deformity with the toe actually crossing up and over the great toe, you can see the progression that can occur with time. Early on, a patient may develop pain without any deformity at all, but as time passes, often the second toe will deviate up and over the great toe, and again, that's why we call it a crossover toe. One of the most difficult things for a patient to do is to isolate the area of pain in the forefoot. And that's because a foot is really a long ways away from the hands, and it's inside the shoe and a sock. When a person first comes in the office and is seen for a crossover toe deformity, often they sense a very large area of pain, and maybe a couple of inches square in their forefoot. And it's our challenge to try to isolate that and to get it down to a very small area of pain so that we can make the correct diagnosis. What we try to do instead of isolating the pain to a broad area is one thinks of like just having a pin, and it would be going from the top of the foot to the bottom of the foot. What we're trying to do is have the patient isolate a small area of pain, top and bottom, and they'll often put a small X there on the top and the bottom of their foot so that when they come to the office, they've really honed it down to a specific area of pain. That's really important for us in our diagnosis. Now, what occurs when a crossover toe develops in its early stages is it's often a rupture of or an elongation of a ligament. Now, it may occur on the bottom of the toe, and as we see in this drawing, with a simulated hammer toe deformity, sometimes a rupture will occur on the side of the toe, and we see in this drawing, and this will occur, the toe will actually deviate inwardly towards the great toe, and then in time, it may cross up and over the great toe. Now, in our practice, we see lots of injuries and sprains and strains, but the history that a typical patient gives when they come in with a crossover second toe is one of no injury at all. Insidious pain develops, and it's usually a vague aching pain that seems to be associated with walking and increased activities and decreases when a person sits or rests. Again, it's really important that we isolate where the pain is coming from because there are other causes, and sometimes I will suggest an injection into one area to see if we can temporarily eradicate or erase the pain with this injection in either a joint or a nerve for a little while. We'll have the patient go out and walk around, sometimes in uncomfortable shoes, and then they'll come back and we'll see if we temporarily made their pain go away. An absence of pain gives us a clue that we're in the right spot. This sometimes will take 2 or 3 office visits, and we will do 2 or 3 different selective injections, and maybe only one of them will work, but that's the key to making the correct diagnosis. Physical examination is very important to determine the exact location of pain, so we may push and pull and probe in the forefoot in order to find the exact location of pain. There are so many different structures in here And they're all very close, and we have to find the exact location of pain. Often we will do a test called a drawer test, in which there is a test to determine if there's any instability in the area of the lesser toe. We will grasp the toes in our hands, and then we will pull up and down to see if there's instability. Now let's look at this exam in an actual patient. A drawer test is performed, and with the toe held with the thumb and index finger, the toe is thrust up and down, which usually creates pain. Early on, when we're treating this problem, we may suggest a change in shoe wear. Another alternative is we'll use a metatarsal pad that is carefully placed in the insole to pad the area just behind the metatarsal head. Early on, there are several treatments that we will try in order to decrease the deformity that occurs with a crossover toe. We can tape the second and third toes together, which we call buddy taping, and what we do is we'll anchor the second and third toes together with a circumferential piece of tape, which is worn during the daytime when a person is walking around. Another little bit more complex taping technique, especially when the toe has started to deform, is to place a piece of tape over the second toe and tape the toe to the bottom of the foot. And you see that in this example. It's important when we do this that often this tape will come loose, and thus we have to put another piece of tape around the foot in order to anchor that tape both around the second toe and to the foot itself. Now another choice is a steroid injection, and while I don't do this as commonly, in the early stages we may inject the toe and then tape the toe to give it stability. Often that is coupled with a metatarsal pad and a soft shoe. While conservative treatment may help in the early treatment of crossover second toe deformities, with time or with more severity, surgery may be necessary. The amount of surgery really depends upon the severity of the deformity, but in general, most of this can be done as an outpatient with regional anesthesia. The nerves in the foot are put to sleep, and if you wish, you can certainly be more sedated. It was actually in 2011 that a group of my fellows and I did the investigational work that defined the problems of a crossover second toe. In this diagram, we see different types, and we've actually graded them as 1, which is a small tear, 2, a little bigger tear, 3, a more extensive tear, and 4 is really a very bad tear of the plantar plate. Using this kind of information, we then developed a surgical technique to repair the plantar plate, which is the surface on the bottom of the foot in the area of the metatarsal that tears and leads to a crossover toe deformity. Let's look at a diagram, a very simplistic diagram of a lesser metatarsal phalangeal joint. These big red pieces of tissue are the ligaments, and on the bottom is what we call the plantar plate. And again, this is very simplistic, but with a plantar plate tear, a tear occurs right in this region, and then if it gets more extensive, the toe will deviate or will cock up in this fashion. And so when we talk about a crossover toe, we're really talking about those ligaments on each side of the joint and on the bottom that control it, and if they degenerate, they can tear. Surgery now is centered with trying to repair those deficits or those torn ligaments. And so what we do is, in surgery, we will take that same metatarsal, and if you see closely here, we cut the bone and we'll tend to shorten it. And then once we shorten it, we can actually get inside the joint and we can effect a repair by placing sutures in that plantar plate and fixing it. At the very end of the procedure, we place some small screws to hold the bones together in a slightly shortened fashion. Now, that's hard to really explain, but let's look at this animated video, which I think will be very helpful in trying to understand exactly what we accomplish when we do this type of surgical repair. We call this a complete plantar plate repair, and you see in this animated example, we made a cut in the skin, and now we're using the power saw to cut that metatarsal, and we extend it proximally. We actually shove it up about 1 centimeter and temporarily pin it. We're going to shorten it, so we take a small segment of bone off, and then we attach a distractor with small pins. This all looks big, but it's a very small space. Now, I've just released the plantar plate, and in it you can see the reddish tissue, which is where the tear is. And now I'm passing suture with an instrument that we developed called the Scorpion. And we put a couple of different sutures in, sometimes with that Scorpion, and sometimes with a little hook suture that we use to pass it. Then we drill some holes in the base of the proximal phalanx because we want to reattach the plantar plate to the proximal phalanx from which it's torn. We pass those sutures through the bone, then we go ahead and we bring the bone back to a probably slightly shortened position. We clamp it, and then we actually fix it with a couple of tiny titanium screws. Once we've done that, we then go ahead and tie the suture, and that in essence is the repair. Sometimes we have to add other sutures to balance the toe from side to side. It's a complex repair in a very small area. This is the state of the art at this point, is a plantar plate repair. But I must tell you that we often will transfer tendons, we'll tighten up other tissue in order to balance that toe as perfectly as possible. We then come to the postoperative care, which I think is important as well. It's very important. We see our patients every week to 10 days to make sure that their toe is in a proper alignment, and then we teach our patients the exercises, both active and passive stretching exercises, to mobilize that toe. The real goal here is for that toe to be as perfectly positioned as possible, for it to touch the ground and to have as much action as possible. I must tell you that this is a very tough and challenging problem, and sometimes while we will get marked improvement, there are still some elements of deviation that are present. I think it's helpful to actually see a patient case in order for you to identify what happens here with the correction. Here's a photograph of a patient's foot that shows a crossover second toe deformity. And this is the preoperative x-ray that was taken at the same time. This is actually at the time of surgery, and you can see an open incision still present. And this is the x-ray afterwards showing the correction. And here we are several years later. This is a photograph of that same foot, and this x-ray demonstrates a very nice alignment of the second toe with a successful correction. Her pain has been eliminated, and her toe has been realigned. So how do patients do with surgery? Well, sometimes we do very little surgery and we are able to achieve really a very nice correction. And sometimes we have to do extensive surgery. And that can all make a difference in how much recovery occurs, how much pain there is, and the type of results. We've actually looked at these results of our crossover second toe patients, and in general, I can tell you that our results are really quite gratifying. I would say by and large that our good and excellent results are in the 80 to 85% range. What kind of things can you expect? Well, I think it's a very slow recovery. It takes time for swelling to go down from the toe, and there can be a fair amount of numbness in and around the surgical area that gradually subsides with the passage of time. The swelling on the bottom of the foot takes the longest to go away. But what we realize is that we're trying to achieve here is to correct and remedy both the pain and the malalignment. And the trade-off is that often you get some stiffness or loss of active motion of your toe. I think that's a decent trade-off. If we can get rid of the pain or reduce it substantially, that pain that causes difficulty with walking, that's a big step forward. Are there risks involved? Well, there are risks involved with surgery. There's always a risk of infection, although it's small. We give antibiotics to minimize that risk. There's a risk that the deformity may recur, it might come back, and there's certainly an element of stiffness that will be there when we're all done. These toes don't have normal motion when we're done. But I do feel that in time, much of that mobility will recur. As far as numbness is concerned, it may take several months for that to resolve. It seems to improve with time. These toes really do take a lot of time to recover from this surgery. Well, what we tried to describe to you is how we diagnose a very common problem, and that's the crossover second toe. We see it a lot in our practice, often associated with other issues. It's a tough treatment. It's much tougher than many of the other things that we treat. And it requires your cooperation, requires my treatment, and us working together in order to get the best possible result.